So it should come as no surprise that official attestation period has started for the 2018 MIPS performance year. It officially opened up January 2nd, and you do have until April 2nd to send in your attestations. It's important to note that for groups that are going to be submitting their providers as individuals versus group reporting, consent does have to be by those providers. Practice administrators can give consent on behalf of the group if they're doing group or virtual reporting. So the difference is really for those individual reportings, they do actually have to get clinicians' consent. And just as a reminder, the data for MIPS, it needs to include all payers for QCDR registries and EHR submissions. Medicare only applies to the claims and web interface submissions. So although MIPS is only going to be affecting your Medicare reimbursements, the completeness of the data must include all payers, and it must include, for group submission, across the whole tax ID, and that would include non-eligible conditions as well. So for 2018, the threshold for data completeness that needs to be submitted for MIPS is 60%. And one thing that CMS has come out and provided additional clarification on what this is intended for is this is supposed to be an accurate representation of your data. The 60% is only to account for areas where you can't access or get a hold of data for reporting, and is not supposed to be intended for selectively removing patients and only submitting 60% of quote-unquote good patients. This is something that CMS has provided a lot of clarification and stress in the last couple months. Just a reminder, for 2018, this is the first time we're going to be actually graded on our cost performance. For 2017, this category information was provided, but it was not included as part of our overall score. So going into 2018 and 2019 performances, we're going to have for 2018 the first time we're going to be graded on our total capital cost and Medicare spending per beneficiary. And then looking into 2019, we are going to have the additional categories of the episode-based care. So just to clarify, the attribution that goes along with calculating your groups or individual providers' attributions for the cost category is broken down. For the total per capita cost, it's plurality of the primary care services rendered, which does mean some of our specialty-only groups are going to have patients that fall into this category for cost and have patients attributed to them. And then for the Medicare spending per beneficiary, we have the plurality of Medicare Part B services billed. For groups that do not have any patients that have been attributed to them, they will not receive a score for this category. Big important item. It is really important to keep track of all of your documentation to support your attestation for up to 6 years. So just a frame of reference, for 2017, that data needs to be kept through to 2023. So as we're looking in the middle of this attestation period for the 2018 submissions, there are certain items we recommend to keep as part of that binder for those 6 years. One of them, of course, being the actual documentation of the submission to CMS. If you're going through a registry, they will be able to provide confirmation that that submission has been made. an actual copy of the security risk assessment report, and that does need to reflect the submission time period. While the same report can be used and updated from year to year, it does actually need to be completed each reporting period. Validation of the EHR certification. So for 2018, you did need to be on either 2014 or 2015 certified EHR, depending on whether you chose those transition measures. And this can actually be obtained through the ONC website. Something that's important to note, especially if you're looking at going through an upgrade and moving from a 2014 to a 2015 certification, you do need to keep documentation that supports the time period for attestation. So if you're attesting for the PI measures for the last half of the year, then it's important that you are able to show that ONC certification for that version during that time. For all the measures that you're submitting for both the PI and quality, we do highly recommend to actually store within the audit binder that year's measure details, as well as documented workflow that was used. It's really important to go ahead and make sure you include screenshots within the EHR. It doesn't have to be for a specific patient, but if that information is ever brought up through a randomized audit by CMS, that you're able to clearly show how the providers are capturing that information within the EHR workflow. For those PI measures, it does require an ONC certified EHR to produce that report. And in your audit binder, you're going to want to include that report that displays the numerator and denominator calculations, but also making sure that it includes the vendor's logo and the time frame that you're going to be attesting within. And then with the IA measures, CMS has actually provided clear breakdown per measure of what should be included in your audit binder. So I've just included a link. As I mentioned, this information is going to be available online after for you to go back and reference. For the additional measures within the PI reporting, for the specialized registry and public health measures, it's really important to have documentation from the state agencies or the registries that you are engaged with, including items like emails, screenshots showing the information within the dashboard, or even actual invoices, receipts showing active engagement during that time period. And so it's important that it actually displays the date of that engagement that is kept within that audit binder. And then for the certified EHR bonus for the IA measure, that is part of the promoting interoperability. That is a yes-no measure, and it's really important that you include a screenshot of the activity actually being completed within the EHR to be able to attest yes to that measure. All right. So that should get us pretty well squared away for 2018. We want to spend a little bit of time talking about what 2019 looks like and what we can kind of learn from the previous years. So CMS did release that in 2017, they actually had 93% of eligible clinicians receive a positive payment adjustment. And that actually is just slightly lower than 95%, which avoided a negative payment adjustment. So between that neutral and positive adjustment, 95% of those eligible clinicians performed exceptionally well for 2017. If we start to break it down into a score. Interesting, the average mean score was 65 points, and then the median was 83. So there was a significant range in the reported scores for 2017. Because of these numbers and the high number of high-performing people, for 2017, the actual max incentive that was rewarded was 1.88%. So that's significantly lower than the up to 4% adjustment that existed for the 2017 reporting year. And we expect a similar adjustment as we look into 2018 and 2019, where CMS has actually estimated a max incentive for 2018 of 2.05% and then 4.69 for the 2019 out of a possible 7% adjustment. So there's a few reasons why these numbers reflect the way they do. CMS has actually predicted for us, and they've been fairly right the past couple years, so within the 2018 final ruling, they actually are estimating that only 74% will actually score into that exceptional performance threshold. And the reason for this breaks down into a few different areas. For 2018 reporting, the minimum points is increasing from the 3 points that it was in 2017 up to 15. The threshold is still at 70%, but now with the introduction of that cost category, our distribution of points is now different, with a less emphasis being placed on quality now. The same trend is expected to continue to 2019, with the same type of increases occurring of the additional 15% on those minimum up to 30 points now being required in 2019, and an exceptional threshold up to 75 now. And additionally, we're going to see that increase in that cost category for 2019, making it a little bit harder and distribution of points different than in the previous years. So before we totally walk away from 2018, we just wanted to touch on, if you haven't actually started on MIPS for the 2018 period, there is still a possibility of reporting, especially if you are less than 15 clinicians. So really starting for making sure that you're at least hitting the minimum threshold is still possible, even if you haven't been tracking throughout the reporting year. And then the last thing with the 2018 reporting, we do really emphasize that if you haven't actively engaged in the MIPS program and always hoping to just plan for hitting that neutral adjustment, these scores do get posted on the Physician Compare site, and so they are publicly out there and available. So always something to kind of think about, that these do get publicly posted out there, and wanting to kind of always put out that best foot forward. So focusing on 2019, as many of you do know, we are going to have the increase of eligible clinicians with the additions of physical therapists, occupational therapists, audiologists, and other clinicians. Our eligibility threshold is the same, greater than 90,000 billed to Medicare, greater than 200 covered services, and covered Medicare beneficiaries served. But in addition to those additional eligible clinicians, we are going to have the option to allow, if you meet one or more, but not all of the thresholds, to actually opt in for 2019. Now, CMS has not completely released how they're planning to allow for this. However, they have come out in that final ruling saying that once you have actually opted in, it is actually irrevocable and can't be changed for the performance year. So what this is meaning for the 2019 performance year is now you're going to have more of your organization possibly engaged in the MIPS program and working towards that attestation, and the possibility of choosing to actually include them towards that potential positive adjustments. And then important to note, the dates, of course, have changed a little bit for the reference segments that looks at the 90,000 and 200 threshold. For 2019, it goes back October 1st, 2017 through September 30th, 2018. And that's going to be what you currently see time frame posted on the CMS website. And then the second time frame that they refer to starts at October 1st of 2018 through September 30th, 2019. So it does actually actively go through into part of the 2019 period to be considered part of the eligible clinicians. And as I mentioned, with the changes that we're going to see with the scores and how they're trending, and this is really due to that increase now of our cost category to 15% and our quality down to 45%. So that cost category, as we were told when the MIPS program originally came out, it's going to continue to increase, affecting that overall score. And of course, what that then means for our final score is our quality is going to have a lower weight than it previously had, as contributing to the overall MIPS final scores. And then, as previously mentioned, of course, our performance threshold is now, for exceptional performance, is now going to be increased to 75. Again, looking at our overall trends from 2017 and what we're expecting for 2018, that is going to make it for us slightly harder to have a positive adjustment. And then CMS did stick with their decision to require in the 2019 reporting period to have a 2015 certified EHR. It's very important to note that your implementation of that 2015 certified EHR must be in place at least 1 day during the reporting period. So if you are reporting through December 31st, it at least has to be in place on December 31st for a full day for it to be considered on that 2015 platform. So if you are actively working on finishing up your 2018 MIPS submission, there are some things, of course, we want you to keep in mind because of the fact that the 2019 MIPS period has actively started. For that quality category, it is still going to be based on that full year, so patients that are being seen currently are going to contribute to that overall score. So where you should be looking at and actively working is take a look at all of your measures that you've previously reported. Our recommendation typically is measures that your providers and your clinicians are used to performing and used to documenting are usually the best place to start when looking at what measures to select for the 2019 time period. That does include a little bit of a caveat that CMS did drop topped out measures, so not all of the same measures are going to be available for 2019 that were previously available for 2018. And then the 2019 measures do change slightly. So reviewing those and seeing what changes are present from measures that you have selected and reported on in previous years is extremely important to account for any changes. Of course, when you're working towards that 75-point threshold in the 2019 reporting year, Education retraining is extremely important. MIPS is not necessarily anything new to a lot of groups. A lot of the measures are extremely similar to things we were seeing back in Meaningful Use and TQM, and therefore this information does get to be very stale, very something that's easily forgotten. So education and retraining are extremely important to kind of keep this information active in the clinician's mind and part of their daily workflows. And then with the changes and the ability to opt in 2019, it's extremely important to provide education and really understand who's going to be affected and contributing to that overall an individual scores now for 2019. If you previously have done individual reporting, there are the additions of the new clinicians that come in, as well as with that opt-out that can provide for potential impact to your Medicare reimbursement by including more providers and high-performing providers in your organization and contribute to that overall improvement. And then naturally, if you're not already on a 2015 certified EHR, you will be required to upgrade. As I mentioned, it at least has to be in place for 1 day during that reporting period, but does need to be completed prior to the 2015. And that may be quite a burden on some of the groups that have high customizations or need to actively engage multiple resources in order to upgrade. And then the last item is looking at and discussing risk adjustment coding. This is one area that the clinicians can actively engage in that cost category to help to impact it by just simply documenting the chronic conditions that they're currently treating on patients that because they are chronic don't go away. However, they do contribute to that overall risk, that overall cost category and can help improve your performance there. We did post a few websites and resources available that will be up after the webinar here today. One thing that we do at CareOptimize is we really actively engage and want to provide as much education out there. So if anybody does have any questions, please feel free to shoot us over. We do still have a few more months for that 2018 MIPS attestation and actively working with groups to make sure that they're prepared for 2019. So our information is at the bottom of the slide here, and please feel free to reach out with any questions. All right. Well, thank you, everybody. I know it brought us directly right to that time. We're going to go ahead and leave the WebEx up if anybody wants to put any questions in the chat, and we will always circle back around with folks as well.